I don't need to use this if you can hear me, but if I'm talking too quietly, I will use the mic. So, okay, I will use the mic. All right. Well, I want to say thank you to Nancy for having me here today. This is a topic that is near and dear to my heart. As she told you, I'm a pediatrician, so I'm not a dentist, and people often make that mistake. They say, well, you're here to talk about oral health or an oral health topic, you must be a dentist, but I'm not. But as a pediatrician, I was constantly getting my patients ready for general anesthesia, and I always thought, like, why do all these kids have to be sedated to have their teeth taken care of? So that's kind of how that interest in oral health began. And obviously part of what we do in pediatrics is vaccinate children to try to prevent disease. And I think the HPV vaccine is something that's been fascinating to watch the evolution in the last few years, as it is one of the vaccines that I've been been able to just focus on and really understand kind of the development of it, how it's been presented to the public, and the response from parents. So I think it's really important that everyone really understand kind of the research, the science, given what we just heard this morning. I think there's a lot of misinformation specifically about the HPV vaccine that I hope that I can clear up for you today. And I hope there'll be questions and things at the end if you guys have things that you're still not sure about. But I think it's really important that oral health practitioners join with medical practitioners to really try to get HPV vaccination really in its rightful place, expanded, and really everyone who can get it should get it. So that's just my no conflicts of interest slide. The first few slides I think are really very simple, and if only I only had to present these 5 slides, I would think that we could be done and I could leave. So we'll just start with how common HPV is. We know that 4 out of 5 people will be infected with one of the over 100 types of HPV virus that are found in nature. So basically almost everyone here in their lives will have experienced one of the types at least, and many people multiple types. HPV definitely causes cancer. There's many studies finding the HPV virus specifically in cervical specimens, but now we're seeing, well, we've been seeing it in other areas of the body. I don't have a pointer, but you can see that it is responsible for over 90% of the cases of cervical cancer and cancer of the anus as well. It's almost all HPV related. And then the oropharyngeal cancer, which is I think the focus of many of the attendees, it's also responsible for 70% of oropharyngeal cancer. Oropharyngeal cancer caused by HPV has been increasing significantly in numbers in the United States, and it's something that we really need to be paying attention to. Previously, oropharyngeal cancer was mostly caused by smoking and alcohol use, were the kind of the risk factors, but now more and more they're finding many of them are HPV positive, and so again, this is a great role where HPV vaccine can help. And we know that the vaccine is effective, and there's estimates that it could eliminate 90% of the cases of cancer caused by HPV. So almost everyone will get exposed to HPV. HPV causes cancer. HPV vaccine prevents cancer. So we should be done. What else do I have to say? We need to understand that HPV vaccine is cancer prevention. That really is the message, and I think that message has been lost in the way the HPV vaccine was initially presented to the public, and people have kind of been sidetracked with lots of other issues that we're going to talk about today. And this is one of the kind of the bigger problems. So there's a lot of parental resistance to HPV vaccine. So HPV vaccine in general is given to children, pre-adolescents at about age 11 to 12. And this is what parents who decline the vaccine cite as the reasons for not going ahead with vaccination that day. As you can see, about 20% of them think it's not needed and not necessary. 14% felt that their provider didn't really recommend it, and so they weren't going to do it. 13% at least, we'll talk more about that, have safety concerns and worry about side effects of vaccination. 12% really don't understand kind of what does HPV cause? I don't know anything about it. I'm not going to get that vaccine. And then 10% of parents will say, well, my child isn't sexually active. Why do they need this vaccine? So we'll start with adolescent vaccination coverage, and I think that's important for everyone to be aware. It's not that these parents refuse all vaccines. They actually, in the United States, we have very good coverage for adolescents. And if I had a pointer, you could see that for the other routine vaccinations that we give at age 11 and 12, so the tetanus, diphtheria, acellular pertussis vaccine, the Tdap, and the meningitis vaccine, we have about 80 to, in some areas, we can have up to 90% of coverage. So adolescents are getting those vaccines, but when we present the Tdap, HPV, meningitis vaccine, parents will say, well, I'll take those two and I won't take the other one. And again, we need to educate the public and kind of figure out why that is, that they're taking the other vaccines that we recommend, but they're refusing HPV vaccine. Overall, these are 2016 numbers, are a little bit better in 2017. We know that for girls, so in the parentheses, you'll see the sex of the child. So again, HPV vaccine was originally recommended only for girls, and so the rates are a little bit higher because we've had a little bit more time with that. So we think about 60% of girls will get at least one dose of HPV vaccine. For boys, you can see the growth has been much faster, actually. The slope of the increase in vaccination has been better, but still only about 50%. For girls who complete the entire series, about 40%. And then for boys down there, you can see about 30% will have the complete vaccination series. So really a long way to go to get up to those 80-90% vaccination levels. This is just a little bit of background on the HPV vaccine. Again, I think because of the way it seems like it's come out in kind of a start and stop, and I think that has confused the public as to why they need the vaccine. So the HPV vaccine was approved by the FDA in 2006. The original recommendation was only for girls, and the Gardasil 4, which was the first vaccine that was approved for use in the United States, contained the HPV types 16, 18, 6, and 11. And that'll become important because we've added, subtracted, we've done a variety of things with the vaccine content. But as you can see there in 2009, they expanded the recommendation to include males to be vaccinated because they figured out that girls in general would get infected by their partners. So if we don't vaccinate the partners, we're not gonna make significant strides. So that was really genius. So in 2009, the recommendation was for males to also be vaccinated. In 2009, there was also another vaccine that was produced called Cervarix, and it only contained the HPV type 16 and 18. It did not contain 6 and 11. HPV type 6 and 11 are the types most commonly associated with genital warts, and I believe pharmaceutical companies picked up on this concern about sexual activity and basically said, well, if you don't want to talk about sex, we'll just talk about the cancer types. So this 2-valent vaccine came out, really wasn't adopted into great use because the Gardasil 4 was previously available. And then in 2014, actually, they were able to expand the HPV types to a 9-valent vaccine. So that's Gardasil 9, that's the vaccine, that's the only vaccine actually available in the United States today. And that has the original 4 valents, the original 4 virus types, so 6, 11, 16, and 18, and then they added 31, 33, 45, 52, and 58. And there'll be a test later, so I hope you guys are all memorizing all of this. And basically those other HPV types were added because they are associated with about 10% of the cancers associated with HPV. So that's kind of the rationale why things have gone the way they have. Initially it was a 3-dose regimen for everybody. And in late 2016, there was a change because the vaccine is so effective in younger patients that they could, if you're vaccinated, if you start the vaccine series before the age of 15, you only need 2 doses. But if you start 15 and over, and if you have any immune compromising conditions, you're on chemotherapy, you have a variety of, is there a question? There is a great question. There isn't at this time. You can get an extra dose, but it's not recommended at this time. So there'll be some more discussions. We're going to talk about the recently expanded age groups. But again, as of December of 2017, Greater than 100 million doses of HPV vaccine have been given around the world. So this is just to go a little bit of support. People say, well, it's a new vaccine. We don't know that much about it. We actually know a lot about it. 100 million doses is a lot of people and a lot of experience. So this is just a little bit of a different kind of schematic just so you understand why the vaccine types are in there. Again, the 6 and 11 are the ones predominantly associated with genital warts, and those were in 2 of the vaccines that were formulated. 16, 18, again, there was just that one vaccine that only had those 2, but 16 and 18 are the most oncogenic. So those are the the virus types that have been most associated with cancer. So it's important that those for sure be in all of the vaccines that are formulated. And again, the addition of these 5 other HPV types that were added to the Gardasil 9, which is what's available in the US. So, and this is why vaccines were formulated in that way. Again, you'll see that for cervical cancer, the most common types, the darker blue bar there, is HPV type 16 and 18. So that is the most common HPV types that are associated with that type of cancer. You will see oropharyngeal cancer on the bottom with that dark blue bar, 16 and 18. But again, the 5 additional HPV types that were added to the Gardasil 9 vaccine, 31, 33, 45, 52, 58, are in the lighter blue, and you'll see them as well, just responsible for a smaller portion of oropharyngeal cancer, but a more significant part of the cervical cancer types. So this is why the 9-valent is really what kids now who are being vaccinated newly should be getting. This is an incredibly busy slide. I don't want you to focus too much on it, but to know it's there. If you have really good glasses or readers, you can see that for the earlier vaccinations, so on the left side of the chart are girls aged 9 to 13 who are vaccinated with 2 doses, and on the right side of the slide are women ages 16 to 26 who got 3 doses. And what's important to note is just basically that the vaccine or the antibody titers for women who are vaccinated at a younger age are nearly double the amount that they are for women who are vaccinated at a later age. This just goes more toward why we need to vaccinate kids early, because the vaccine works better. The antibody levels are higher, they last at a significant level for a longer period of time. And that's seen for this chart displays the 16 and 18. Again, these are the cancer types that we really, really want to be sure we're focusing on, want to be sure that kids are vaccinated against. But you can see that even after 36 months, the vaccine levels are still quite a bit more than they are for the older girls. So again, if we vaccinate early, and number one, they also get just 2 doses instead of 3 doses, so that's a way to kind of, I don't want to say sell it, but to encourage it, because they can save themselves at least 1 shot, but also it's more effective. The vaccine, the antibody titers are just so much more robust. This is another really busy slide, but what it's trying to depict here is, if you see in the upper section of the chart, there's 2 little boxes, a darker black box and a gray box. The darker box is 2003 to 2006, and the gray box is 2011 to 2014. The difference of that is before vaccine was introduced and after vaccine was introduced. And all that I want you to see is that for the HPV types, which are these, right here, gosh, it really doesn't display very well, but this is 16, 18, 6, and 11 in this box here on the left-hand side. All I want you to notice is the significant decline from prior to vaccine exposure in the United States to the little gray bar. You can hardly see it because it's so much smaller. How much of a significant drop there was after vaccine was introduced. So again, the red asterisk area is just so you can see those are the other HPV types that were not included in the vaccine, and there was no significant decline in those HPV types. But for the HPV types that were included in the vaccine, there was a significant decrease from prior to vaccine availability to post-vaccine availability. So again, the vaccine works, and it decreases the incidence of those viruses in the community. This is a slide from data from Australia. This is what they did was looked at the percent of decrease. So in this slide, actually, the higher the bar, the better it is. That means that there was a more significant decrease in precancerous findings on cervical histology. So when they do pap smears and they look at cells, when the bars are higher, that was a more significant decrease in abnormal findings or in abnormal or precancers. And what they found was for each of these age groups are the age that the child was when vaccine was completed. So for the girls who were vaccinated under the age of 14, what they found was a 75% decrease in any kind of precancerous findings on histology. It's really significant. I mean, great effort. Again, Australia has done something amazing where they had a very, very thoughtful approach where they've offered vaccine to everyone starting in 2007. Vaccine was free and required, and I'm going to show you another slide, but they've just, it's really a tremendous kind of public health achievement that they're working on in Australia, where they're just really a very coordinated effort to really get HPV vaccine out and get all their girls vaccinated, and the boys when the recommendation came out. But they've been able to really show significant decreases in precancers, and then subsequently, obviously, if you don't have precancer, you're not going to develop cancer. So these things these results are very exciting. This is a recent New York Times article that Australia thinks they're going to be able to eliminate cervical cancer completely. Again, and this is the kind of the fruits of their labors, everything that they've done working on HPV vaccination and exposing the entire population. According to their estimates, by 2028, less than 4 women in 100,000 will be diagnosed with cervical cancer, and by 2066, they think less than 1 woman per 100,000 women in Australia will be diagnosed with cancer. That is amazing, and that's like that's going to go down with like amazing public health achievements like community water fluoridation. So cervical cancer takes a longer time to develop. It can take 10, 20 years from when the patient is infected to the times you find cancer. So girls can be infected in their teenage years when they're first being exposed to different partners and different HPV types, but typically diagnosis of cervical cancer is in the mid-20s, late 20s, 30s, 40s, where genital warts, if you're exposed to the HPV types that cause them, develop much sooner. They think in about 2 or 3 years, if you're going to have genital warts or you've been exposed to HPV type 6 and 11, you'll be diagnosed with genital warts if you are so unlucky. And what they found was, again, 2007 being that divided line. If girls were vaccinated under the age of 21, so really before they're exposed to different types of HPV virus types, the decrease was almost to 0. So if you see, that's the blue line in that chart there. Girls under the age of 21 who had about 8% of them were being diagnosed with genital warts at their first visit. And then by 2011, so just a couple of years right after HPV vaccine was introduced, the cases were down to almost 0. So again, the HPV vaccine is effective, and it's most effective the younger that you do it. So again, before they're exposed to any of these types is when the vaccine really can prevent significant disease and certainly cancer. I need a little drink. This is a slide that I'll just walk you through. I love this slide. This is a slide called a Kaplan-Meier curve. And these they show you in medical school, and it's called the survival slide. So it starts with everyone is alive and well, and basically as time goes on, the condition that you're looking at is happening and not continuing. And the condition that they're looking at here is virginity, so lack of sexual activity. So in the beginning here, age 11, all of these different populations of kids are all virgins. None of them have been exposed to sexual activity. But then starting right at 12, you'll see this darker blue line, which is African American males. You'll see that their virginity doesn't survive, it starts to go down. So they start being exposed to sexual activity. And then, so about 10% of African American males, and you'll see that solid green line, which is Hispanic males, also begin, a small percentage of them around age 12. And as time goes on, obviously here by age 18, for African American males, about 25% of them haven't initiated sexual activity, but about 75% have. And all of that all shows you, again, that we need to be getting these kids about 11 or 12, because I know parents don't want to talk about it and people don't want to think about it, but kids are getting involved in sexual activity right about those ages, and by the end of high school, the fact is most kids have had some kind of sexual activity. So this is something that parents really don't want to talk about and really don't want to face. What pediatricians have started recommending is presenting it as, you may not want to talk about that today, but don't you want grandchildren someday? So that if you want your child to be in a loving relationship, that's going to be part of it, and that's a great thing. But this is something that we really come up against really on a daily basis in clinic. People are just super worried, but why? But not my baby, it's not going to happen. It is going to happen, and it's okay. And this is just a little humor. So that just gets to the point of, if we want to prevent something, what should we be doing? So when should this bicycle helmet go on? Should it go before they get on their bike, when they're riding in the street, when the car is heading right at them, after the car hits them? You know when it should go on. So HPV vaccine is recommended at age 11 or 12 years. You can actually do it as young as 9 years of age. And for some girls really do go through earlier puberty, and a 10-year-old girl can look like she's 16. Those kids, have a little bit higher risk for engaging in sexual activity, so it's important to kind of alter the schedule as we see fit and really recommend it. But you can recommend it at age 9, and I've had now parents, as they are hearing more and more, will say, well, I heard my kid can get that vaccine, can they get that today? And I'm like, absolutely. If they're 9 or older, they're gonna get that vaccine. But in general, it's 11 or 12 is when we're mostly doing it, because we can pair it with the other vaccines that we do at the same time, that tetanus vaccine and that meningitis vaccine. The goal is for kids to be vaccinated by their 13th birthday. So that means they've completed the whole thing we started, they've gotten their second dose, hopefully, if they are otherwise healthy. They just need 2 doses and they're done. The vaccine is available for kids who are older, but again, oh yes, there's a question. Good question. That's on the next slide. But between the first and second doses for the kids who are on the 2-dose regimen, the minimum interval is 5 months, but 6 months is really kind of how we do it. But you can vaccinate older kids, and I have another slide coming. You can vaccinate even adults now. But the original recommendations were to vaccinate girls up to the age of 26 years of age, males up to 21 years of age, unless they were involved in what's termed high-risk behavior. So men having sex with men, and other situations that would put them at a little bit higher risk. You could vaccinate up to age 26. This is the vaccine schedule. So again, if they start the vaccine before age 15, they only need 2 doses. They need to be separated by about 6 months, with the minimum interval being 5 months. If they start after 15 or older, they need 3 doses. The first dose given, and then the second dose given about 1 to 2 months, and then 6 months after the first dose, the last dose, and then they should be finished. Oh, my time is up? Okay, all right. Well, let me not neglect this part. So recently the FDA has approved HPV vaccine for people 27 to 45. Again, there's some discussion, there's some controversy, only because we're not sure, once you've been exposed to different types of HPV viruses, how effective the vaccine will be. But the studies that they did showed an 88% reduction in cancer types. So that's something that's really exciting. We'll see more if insurance is going to cover it, because the HPV vaccine is about $400, and so people will have to decide if they want to pay that themselves or have their insurance cover it. Okay. Oh, yes. Okay. All right. All right, Jenny.
Oh, here you go. If you want to give your scale on what you say.
Okay. I want to briefly tell you that the HPV vaccine has been studied and it is safe. There have been, again, more than 100 million doses given. The only side effects that have been noted are syncope and redness and pain at the site of the injection, and know that those kinds of side effects are associated with all vaccines. Lots of people complain that their vaccines hurt. If you've had a tetanus shot in the last 10 years, that really hurts too. Syncope is something that children of all ages and even adults can get associated with vaccination. It's not unique to the HPV vaccine, but there was a lot of discussion about that. HPV vaccine does not increase high-risk sexual activity and doesn't cause any earlier initiation of a sexual debut either. Sorry, I gotta go quick. All right. Okay. So this is the new recommendation for a presumptive recommendation. And that means that when you see your provider, if you have your child there, or your grandchild, or whoever, that you basically presented as you're going to do this, not do you want to do this. So you would say, Sophia's 11, she's due for 3 vaccines today. We're going to give her the vaccines that help prevent meningitis, HPV cancers, and pertussis. We're going to give those shots today. And then if a parent says, oh, I have a question, or I don't know about that, that you can then, kind of obviously entertain that discussion and make sure they feel comfortable with the choices that they're making. But we know that if we don't present it that way, parents have more concerns. If you say, I'm going to give the ones that are required for school, the tetanus shot and the meningitis one, and then you can decide if you want HPV, that just is not the best way to present it. And parents will think, well, if it's not required for school, maybe it's not good, maybe it's not safe, maybe she doesn't need it. So to really just say, we're going to give 3 vaccines today. These vaccines are going to prevent pertussis, HPV cancers, and meningitis, and we're going to do those today. And most parents understand that and kind of will move forward. So it's a whole different way of presenting vaccinations than we previously did. So that's just kind of the way that pediatricians and family practitioners are really kind of changing the message. I apologize. Do you have slides?
Do you know where my slides are? Do you know where my slides are? I don't know. All right, so I'll get started while we pull up my slides. I hope you heard your prevention role in this. Did Dr. Seymour and Dr. Crespo get to you that sort of thing? You have a big role in this, right? You are an educator in this. Whatever role you're playing in your clinical setting or in your community, we need you, all right? So I come from this from the public health standpoint. I am a sexual health educator by training. I am the drug, sex, and rock and roll lady, right? So I'm not afraid of sex, right? And that's what I talk about. And about a decade ago, I was in a giant oral health forum. It's just one of those serendipity moments. There had to be there was definitely over 500 people in the room. And I was sitting there thinking, I'm so tired of HPV being a problem, and looking at all these people and thinking, all of you could be the solution. Look at all you providers out here that are oral health professionals. And so I stood up and said, I think it would be great if we started recommending this HPV vaccine since you all see young people so often. Silence. Absolute dead silence. And I could have taken it as a moment to say, that's it, I'm never mentioning that in an oral health forum again. Instead, I took it as a challenge. Okay? So I think I'm a little bit older than Dr. Seymour, I don't know, but I want to retire, but I want to retire only when we no longer have to talk about this as an oral health disease. All right? So I need your help because I am not working the rest of my life. I love public health so much, but I'm not going to keep doing this forever because we're going to shut it down. Just a couple of funding things, and there's a piece of paper coming around. It does ask for some information on you because the Centers for Disease Control is really interested in finding out who's finding about HPV vaccine from a non-clinical setting like a doctor's office and that kind of thing. So anyway. All right, so oral health is general health. I think we have all tried to hone this point down, and we recently have some statements from our oral health community that really send this home. And I think it's really important for us to recognize, and as we were saying today, we must recognize that all oral health and general health are inseparable. And so this is where, again, I need your help. Again, more strategic goals around this issue. This is a public health issue that isn't just about our pediatric clinics. So we have some support too. The initial thing, the crickets in the room, over a decade ago was like, well, the ADA doesn't support this. We don't really want to do this. Well, things have changed, thank goodness, all right? So you have the ADA behind us, and they are supporting that we talk about vaccine counseling. So something so exciting, I almost fell out of my chair. You know, if you live long enough, your public health dreams come true, right? So thank goodness. By the way, my son was hit by a car this summer. My teenage son was hit by a car. He did have his helmet on, saved his life. He walked away from the injury. Anyway, so it is good to put those helmets on before you go riding, right? And it's good to get vaccinated before you initiate oral sex, all right? So Honolulu, I wasn't there. No one invited me, but I had a party in my own chair this last week when the ADA put out a resolution. The ADA urges dentists to support the use and administration of the HPV vaccine. All right? Oh my goodness, we did it! We did it! I'm so excited. All right? So recognizing that it is a way to help prevent infection of the types of HPV associated with oral cancers, according to their resolution. Okay? So now we don't have to say, well, I'm doing this on the side. It's a personal public health thing. The ADA is behind us. All right? That is big. Okay? So that was hot off the press. And look at it, they say that there's absolute evidence. There's no controversy about this, so let's get going. So let's get those vaccines used. We heard a lot about what kind of cancers we have here. 50,000 new cancers of oral cancer in 2018. It's time to get these down. We want to shut this down, and we have an opportunity, and it lies with you and your work. The other important part is that the young people are in your offices, all right? So 74.3% of Minnesota adults ages 18 and older report having had at least one past year dental visit. That's, I mean, those are 4 years old, but that's a pretty big number, right? That's a good number. And remember, now we can put this vaccine all the way up to age 74. So, was it 74, I think? So, and we just heard from Dr. Seymour that the most common patient load is going to be over in their 60s and older. And I have some news for some of you, but they're still having sex. Just saying. In fact, when I work with a lot of health educators, one of our concerns right now is how to talk to older adults about their sexual activity and re-emerging sexual practices that they haven't participated in a new partnership in a while. But the more important part of this is, well, we have lots of adults in our chairs. We also have almost half of young people in our chairs, right? They are coming. They are getting visits, all right? And so you are there in the important part. And they are also in this prime age. 41.9% of youth of all races, all ages 15 to 19. They're in the prime age for catch-up vaccine, right? So if they initiate after 15 or over, they need the 3. But if they've started, they only need the 2, so they could still catch up, right? So there they are, sitting right in front of you, right? All right. So if we compare this to medical visits, once again, about 1/3 of adolescents have had a medical visit for 4 or more years of continuous enrollment and had no preventive care. So what the bottom line of this is that you do see young people that have not been counseled in their pediatric office. They're actually sitting in your chair, and there's an interesting dichotomy when we're thinking about health disparities, is that, as you well know, we have health disparities in oral health. We have many health disparities throughout this country in all areas of care. But one of the dichotomies is that in this particular vaccine in Minnesota, we have some of our young people who are most likely to have some of the health disparities in care. They actually have better vaccine rates. And so that's just it's an interesting dichotomy in public health. But what that means then is that you should not assume that the person receiving oral health care in your office as a young person has already been vaccinated, because if they are a member of a more likely to be served group in Minnesota, they are also a member of the less likely to have been vaccinated. That doesn't usually happen in public health, but it happens in HPV vaccine. All right? So, have I convinced you have a role? I hope so. If you need more talking to, I'll be here for lunch. So there are lots of resources to get this done. And here are just a few, and these slides are all available for you through a link that they'll be sending you. So with this ADA recommendation, you can now, if you're working in a clinical setting, in an office visit setting, we have lots of resources for this, right? And so here are just a few. The most important part is that we need to train on this. If the idea that you have to talk about HPV is a little nerve-wracking, and I certainly appreciate that every month I teach residents on rotation in pediatrics, and this idea about bringing up sexual health is often a new challenge for them that they're working on. So I do totally recognize this. So we need to train on this. One of the ways that I try to help this is that I do have young people who are actors, and they train providers on talking about HPV in a clinical setting, all right? So if that's something you ever want, we have oral health scenarios, and we'll be happy to bring one of my young people out with us. We'll come to your clinic or your office or your community setting, and we'll help train your team on how to bring this up, how to have this discussion. And then recognize, too, your big role, right? You are a prevention specialist. Okay, so we heard this morning that in our panel that one of the best places to do is to start at home, right? So my dental hygienist hero, she and I have been seeing each other for I think about 20 years. I was just trying to put it together. And she came to I saw her, I was like, you should come to this training, right? So I got her to come, starting at home. And she brought a lot of her colleagues from a South Minneapolis dental practice. And so they went to the training, they learned that they too have a role in HPV prevention. They saw their role and they decided to grab it. So I followed up with them 6 months later, and they are talking about HPV in their clinic. She has had no resistance from parents. They have the spiel down. She says she has young people in her life, and she says, I'm going to recommend this for my children, and I am giving them the vaccine. I hope you will too. And so her recent quote to me was, I attended the Spring 2018 CEU on HPV and counseling my patients. I was convinced to start trying to recommend. It's been a total success. I got started right away and haven't stopped. And it's just one of those things where she was so surprised how people are actually very supportive. And even those who have vaccinated say, oh, thank you for recommending. You know, they're excited. This is something that she has a very active role in, and her clinic has really held on to and made happen. So I'm hoping that you all will see that you can do this too. All right? People don't start going, oh, you know, as an example, what we just heard from Dr. Crespo too, you don't start out, well, HPV is related to oral sex, and your kid's going to start having oral sex, so I need to talk to you about this. Like, no one does that, right? We're not going to do that. But that's the fear that talks behind us, like that we have to start out like this, right? No, HPV is related to a cancer we can shut down. We do not need to get this cancer. We are shutting this down in other countries and in other states where they have been more aggressive around this recommendation, and let's do it in Minnesota. Minnesota's always a leader. I want to be a leader. Let's get this done, right? So I'm counting on you to all be that leader to help shut down this vaccine. Shut down this disease and recommend this vaccine. No, not the other way around. That was disinformation. Screw it, put that away. All right? No, I'm counting on all of you because we really can get this done. And my dream, my total public health dream, is that no one gets any of this virus that was preventable. All right? And we will always have a few who don't want to vaccinate. I'm not here to say you absolutely have to vaccinate if you don't want to vaccinate, right? But we need enough people who are willing to get the vaccine vaccinated so that those who don't are also protected, because every child deserves this protection. Every child deserves this protection. So thank you very much. I have a question here. Yeah, well, we've been we've been doing on this. I was just talking I was doing my recruiting over at Normandale. So yes, I think we are, and you know, the University of Minnesota has really embraced a more public health approach to dentistry, or you know, they're in the process of that. So we keep talking and we keep talking. But the biggest thing I actually needed was my personal party in my chair on the 10th, on October 22nd. That just happened because I needed that. All right, because people won't go against their organization, but they will go with it. And so with that, the floodgates just opened. And so I will bring my message to whoever wants to hear it. I also want to mention too, we had some other challenges that have also just recently. So how many of you here from Health Partners? Anybody here from Health Partners? Oh, well, yes. So we were just talking. And so Health Partners has now linked their dental records to their medical records. So what an opportunity, right? And I hope that'll happen across the board. That doesn't happen in every care system because it's not possible in every care system. But as we get smarter and better, we will do what needs to be done so that young people do not walk away with a vaccine-preventable disease.